Welcome to This Week in Orthopedics. This week we're covering 10 notable papers spanning the impact of metabolic disease on surgical outcomes, new insights on technology in arthroplasty, and refinements in spine and sports medicine techniques. Let's dive in. First, we'll look at a cluster of papers addressing the growing challenge of managing orthopedic conditions in patients with diabetes and obesity. In Clinical Orthopedics and Related Research, Yamada and colleagues investigated how diabetes affects outcomes after adult spinal deformity surgery. In a propensity-matched study of 63 patients with diabetes versus 126 without, they found that diabetes was associated with more than double the odds of proximal junctional failure, which occurred in 19% of patients with diabetes versus just 9% of controls. This also corresponded to lower revision-free survivorship at 2 years. Interestingly, patient-reported outcomes were similar between groups, but the increased mechanical failure rate is a critical finding for preoperative counseling and surgical planning. This increased risk of failure in diabetic patients may be linked to underlying biological mechanisms, a topic explored in a basic science study in the Journal of Shoulder and Elbow Surgery. Wang and colleagues found that in patients with diabetes and rotator cuff tears, there was significantly elevated synovial inflammation driven by a molecule called MCP1. This pathway leads to pro-inflammatory M1 macrophage polarization, which aggravates synovitis and accelerates tendon degeneration. While this study was on rotator cuff disease, it offers a potential molecular explanation for the poor tissue healing and higher complication rates seen in other areas, like the spine. Staying on the theme of metabolic disease, managing obesity prior to total knee arthroplasty is a common clinical challenge. A study in knee surgery, sports traumatology arthroscopy, compared two major weight loss strategies, GLP-1 receptor agonists and bariatric surgery. Ziegler and colleagues used a large database to propensity match over 1,600 TKA patients in each group. The results at 90 days were notable. While both interventions led to similar complication rates compared to obese controls who had no intervention, the GLP-1 group had significantly lower rates of several key complications compared to the bariatric surgery group. This included roughly half the rate of DVT or PE and lower rates of transfusions, any surgical complication, any medical complication, and readmissions. This suggests that for preoperative weight loss before TKA, GLP-1 agonists may carry a more favorable short-term safety profile. Next, we turn to arthroplasty, with several papers examining the real-world impact of new technologies and a critical look at our diagnostic criteria. Robotic-assisted total hip arthroplasty is gaining popularity, with the promise of improved component positioning and better outcomes. A large study from the American Joint Replacement Registry puts this to the test. Kirchner and colleagues analyzed over 120,000 primary THAs in Medicare patients. After adjusting for confounding variables, they found no difference in the risk of all-cause revision at 2 years between robotic-assisted and conventional THA. However, the robotic group did have a significantly lower risk of revision for dislocation, about half the risk, at 0.3% versus 0.6%. The authors conclude that while robotics may help mitigate dislocation risk, its effect on overall implant survival remains unproven, urging caution before widespread adoption. Moving to the knee, a secondary analysis of a randomized trial in Acta Orthopedica looked at how fixation method affects periprosthetic bone density. Alton and colleagues used DEXA scans to track bone mineral density changes over 2 years in patients with cemented versus uncemented TKAs. They found that uncemented femoral components were associated with significantly more bone loss in the anterior flange region, a 33% decrease in bone mineral density compared to a 21% decrease in the cemented group. This suggests greater stress shielding with uncemented femoral fixation, a finding that could have long-term implications for implant stability, though its clinical significance is still uncertain. Artificial intelligence is another technology poised to change practice. In the Journal of Bone and Joint Surgery, Kim and colleagues performed a cost-effectiveness analysis of an AI tool for automated Kellgren-Lawrence grading of knee osteoarthritis in the South Korean healthcare system. Their model found that using AI to assist with grading could lead to earlier non-operative treatment, ultimately saving over $3,000 in lifetime costs and improving quality-adjusted life years compared to conventional human reading. However, the authors note substantial uncertainty. A probabilistic sensitivity analysis showed only a 55% chance of the AI strategy being cost-effective, highlighting the need for more real-world validation before we can be confident in its economic value. Perhaps the most critical paper this week for arthroplasty surgeons is a methodological audit. Parthasarathi and an independent consortium re-examined the 2025 meta-analysis that underpins the new Unified Periprosthetic Joint Infection Criteria. Their audit uncovered what they term critical limitations in the original paper. Most strikingly, they found a data integrity discrepancy where false positive and false negative counts were swapped for all included studies, rendering the original results unreliable. After correcting this and other methodological issues, their reanalysis found that synovial fluid white blood cell count and PMN percentage are actually poor standalone rule-in tests for PJI. With a positive predictive value often below 90% at typical PJI prevalence rates, a positive result on its own is not sufficient to confirm infection. This paper directly challenges the foundation of the new international consensus criteria and suggests we need to be much more cautious when interpreting these common lab values. Finally, we have 3 papers that offer nuanced guidance for common procedures in spine and sports medicine. For patients undergoing lumbar spine surgery, effective postoperative pain control is paramount. A randomized controlled trial in clinical orthopedics and related research by Reisner and colleagues evaluated adjuvants for ultrasound-guided erector spinae plane blocks. They compared ropivacaine alone to ropivacaine with either dexamethasone or dexmedetomidine. Both adjuvants significantly prolonged analgesia. Dexmedetomidine provided the longest time to first rescue opioid at about 15.5 hours, compared to 12.7 hours for dexamethasone and just 6.2 hours for ropivacaine alone. However, dexamethasone was better at reducing systemic inflammatory markers. This suggests a tailored approach. Dexmedetomidine might be preferred for maximizing early analgesia, while dexamethasone could be beneficial for its anti-inflammatory effects and reducing overall opioid use. In hip preservation, the role of surgery for pincer-type femoroacetabular impingement has been debated. A study in the American Journal of Sports Medicine provides some surprising midterm data. Iyer and colleagues followed patients who underwent primary arthroscopic labral repair for severe acetabular overcoverage, defined as a lateral center edge angle of 40 degrees or more. They compared them to a matched group of non-dysplastic controls. At a mean 8-year follow-up, both groups had similar, satisfactory patient-reported outcomes. The striking finding was the conversion rate to total hip arthroplasty, only 7% in the pincer group, compared to 19% in the control group. This was true even if the overcoverage wasn't fully corrected surgically. The findings suggest that acetabular overcoverage, while a source of impingement, might also be chondroprotective, challenging some of our assumptions about pincer morphology. Staying in sports medicine, a sophisticated cadaveric study in the American Journal of Sports Medicine sheds light on the complex interplay between the ACL, the medial meniscus, and posterior tibial slope. Rasmussen and colleagues used a robotic testing system to show that in an ACL reconstruction, repairing a concomitant medial meniscus ramp tear is crucial for restoring normal anterior tibial translation. If the ramp tear is left unrepaired, the knee remains unstable. Furthermore, in knees with a subtotal medial meniscectomy, stability is compromised if the posterior tibial slope is greater than 12 degrees. In these specific cases of high slope and meniscal deficiency, the authors suggest that a slope-reducing tibial osteotomy may be necessary to protect the ACL graft from excessive forces. This provides important biomechanical rationale for addressing both meniscal pathology and background alignment during ACL surgery. If you only have time for one paper this week, make it the methodological audit by Parthasarathi and colleagues in clinical orthopedics and related research. It's a rare and crucial piece of work that directly challenges the evidence base for a major international consensus guideline. This paper is essential reading for any arthroplasty surgeon, as it fundamentally changes how we should interpret synovial fluid cell counts in the workup for PJI. Here are the key takeaways from this week in orthopedics. First, in patients with diabetes, be aware of a significantly increased risk of mechanical complications like proximal junctional failure after major spine surgery, And consider that underlying inflammatory pathways may be driving poor healing in conditions like rotator cuff tears. Second, in arthroplasty, robotic-assisted THA appears to reduce the risk of early revision for dislocation, but not all-cause revision at 2 years. Also, be aware that uncemented femoral components in TKA may lead to more anterior stress shielding. Third, critically, the evidence supporting synovial fluid, WBC, and PMN counts as standalone rule-in tests for PJI is flawed. Do not rely on a single positive value to diagnose infection. A comprehensive workup remains essential. Fourth, for pre-TKA weight loss, GLP-1 agonists may offer a safer short-term complication profile compared to bariatric surgery. Finally, in ACL reconstruction, always repair a medial meniscus ramp tear. For patients with high tibial slope and a subtotal meniscectomy, consider a slope-reducing osteotomy to protect the graft. That's your roundup for This Week in Orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.